Dr. Eaton is a board-certified hospice and palliative care physician who has worked with the elderly in the areas of nephrology and thus palliative medicine since 1981. She is currently the medical director for Valley Healthcare and Rehabilitation and is also a physician at St. Vincent Healthcare Physician Network. She notes that care for the elderly has evolved over the past 30 years. She's seen many changes. Her current interest lies in caring for these vulnerable individuals, being their spokesperson, and helping people understand the disease processes in the elderly. Well, being one of 3 geriatric nurse practitioners in the state, I had a wide variety of options in which to work, and I came to work at St. Vincent's Healthcare because I wanted to work with this amazing woman. She is wonderful. She loves to educate those around her, and she's a great team player. So please welcome Dr. Lottie Eaton.
There we go. Okay, can you hear me now? All right. Okay. Well, this talk started because we needed to have a breakout session, and I volunteered, and I said we should have something on ethics, because I think what we do in the elderly is very much involved with ethics. And you have to, I think working with the elderly is sort of like going shopping. You can buy everything in the store, but should you? You know, you can do many things for them, but should you? So that's why I'm thinking, you know, we should work with ethics. And I thought, well, maybe we should talk about ethics in nutrition, ethics in sexuality, ethics and other things. And I thought, nah, sexuality, I'm just not really comfortable with that. I'm more comfortable with nutrition because my last name is Eaton, eat on, and I do love to eat. So, well, there's going to be 3 principles we're going to work on for ethics, and I'm going to try to tie it in so you can understand some of the disease processes. All of these slides are on your little flash drive you got, so you can scratch, you can doodle, or whatever you want to do. We're going to work on beneficence, proportionate and disproportionate means, and autonomy. Beneficence basically means do no harm. And these are all Latin words. When you work for St. Vincent's, you get to learn Latin words. And so, the main thing, again, when you're dealing with the elderly, you want to look at what you're doing, examine what you're doing, to make sure of what the short and long-term processes and how it's going to work. There's one chair down here in front. That's my boss voice. Okay, so you know this. People who've worked with me know this. So what we're going to do, we're going to be doing no harm, attempt to do no harm. We're going to look at proportionate, disproportionate. Basically, it means benefit and burden. What's the benefit and what's the burden of what we're going to be doing? And autonomy. This is a strange one because when we're dealing with the elderly, we're always thinking that most of them are demented. They may be. They may have varying degrees of dementia in varying aspects of their life. So they may be able to tell you exactly what they'd want to eat. They may be able to tell you that what they want and they don't want, but they may not be consistent in all areas. So when you do your mini-mental, you do your executive functioning, things like this, it may not be consistent. And when you talk with a speech therapist or you talk with your neuropsychologist for their neuropsych evaluation, you can see how it varies. And what you want to do is to work with the area that they can work with. We're going to be talking about capacity. And when you're talking with somebody about a capacity, this is the big one in the nursing homes. And again, I do nursing home work now, only long-term care. And it's fun. It's much easier than doing nephrology. For one, I get to talk with the people. I don't have to concentrate on keeping them alive. I can concentrate on quality of life for them. And I think that's an important portion of it. When we're talking about capacity, we want them to be able to understand what you're talking to them about and be able to understand the consequences of what you're talking about. They can make decisions that are consistent with what their own values are. And they'd be able to demonstrate the ability to communicate that back to you, okay? When you're talking, as we heard earlier, when people are talking about their advanced directives, talking with their families about what they would want, what they don't want when they get older, those are excellent holiday conversations. And again, that's an excellent gift that you can have, that you can give to your parents, your family, and they can give to you. Because otherwise, you're caught, and you've all been caught in those situations if you have family members. But this is something that when your people are talking about their advance directives, this is what you want them to be concerned about. Something that's consistent with their own values. Not whether they want to be intubated or coded or whatever, but what are their values, and that's what you want to listen to. Competence is a legal term. We do capacity, the lawyers and the judges do competence. So, you know, somebody may be declared that they have to have a guardian, they have to go to court to get a guardian, and declared to have the incompetence. Okay. Now, when we age, we have several things that happen to us. We have life, and that includes, you know, accidents, surgeries, all sorts of things that are external that come to us. And sometimes we have a choice, sometimes we don't have a choice. Sorry, I have to sip water. And then we have illnesses. Sometimes we have a choice in those, and sometimes we don't. You know, sometimes diabetes, hypertension, some of those are inherited, some of those because of something that happens to us. You know, we may have an accident, we ended up with an amputation, and therefore, because of the amputation and all of the muscle things that happen after you have an amputation and change in body mechanics, you may have different illnesses related to that, or depending on your life's work. You know, you see most of the farmers and ranchers have significant arthritis. Ranching women don't have much osteoporosis, but they have bad arthritis because they've been out in the sun, they've been lifting weights, they've maintained their bones. And so, that's it. But genetics is important for us. You know, I have a strong family history of heart disease. I'm just crossing my fingers that I don't have my MI until I'm 75. But I figure, you know, women have 15-year lag on men, so I should be okay with that. Socioeconomic factors are very important because depending on what money you came in, how you were raised, what was your diet when you were growing up, what was your diet now, how much access do you have to health care, how much access do you have to adequate nutrition. So socioeconomic factors are very important in the aging process. As we heard this morning, people who have major illnesses, major stresses, people with diabetes, they age tremendously. You know, we used to see people with diabetes. I would always have these type 1 diabetics, insulin dependent. They were 30. They were already, they needed dialysis at that time because they were diagnosed with diabetes at age of 5 or 4. That's a huge aging process. And so again, looking at those things is very important to be keeping that in mind as we're looking at somebody who's aging. Some of these were alluded to this morning, things that happen to us as we get older. We lose our muscle mass. We don't always lose our fat, but we lose our muscle mass unless we maintain our structure, our activities. You know, we do have women who are running and doing all sorts of things in their 80s, 90s, and 100s. Bone mass does decrease as we get older for a variety of reasons. At this latitude, we don't have very much vitamin D. We have vitamin D deficiency, which decreases calcium absorption. We have less access to calcium. You know, the women who were in their 80s and 90s probably had more milk than people of my age and the baby boomers. We probably didn't have as much milk. And the women who were probably 10 to 20 years younger than us probably had less. So they're going to have maybe some more osteoporosis because less access to calcium in their diet as they were growing up. And also because as you get older, your kidney function decreases, and therefore you have a worse calcium, phosphorus, bone metabolism. That's the nephrologist talking. And so, you know, that's all part of it. And also with decreased exercise, as we do less. Well, I'll do that tomorrow. I don't need to do that anymore. I've done that already. So then your bone mass decreases. Organs get worse as we get older. You know, over the age of 40, it is true that you do start deteriorating over the age of 40. Physiologically, you can read the books, and you do change over the age of 40. You are over the hill. In spite of the fact that, you know, until you're age 70, you're still, you know, in your mind, you're still doing fine. You know, if somebody asks me, what's your age? I have a hard time to decide what my age is that day because it depends on how I feel. I may feel 35, 45, 55. So, again, you know, your age that you're born is something you give to somebody else for your identification. It doesn't tell you how old you are. Okay? And basal energy metabolism changes. It fluctuates. There's less The elderly are less able to handle that. They have a different response to exercise. They're always hot, they're always cold. As you know, when you have them in a room, they have their sweater on, their sweater off, and it's all related to that. Their vision gets worse. As we heard this morning, trying to them to climb stairs. How many times have you served fish, potatoes, and cauliflower on a white plate? When you have decreased vision, you can't see it. So, and you go in these rooms, and they need to have bright lights so they can see things. So again, if you can't see your food, you can't eat it. So again, that's part of it. Hearing goes down. They have decreased high frequency. They can't discriminate the sounds. Things all sound together. If you've ever gone for a hearing test, you know that, and they give you all these words, and you're supposed to repeat them back. And it's interesting what you say sometimes because you just can't quite get it right. So smell and taste deteriorate. I read that people that open, regular Campbell's tomato soup have to add a lot of salt to it so it tastes good to them. At our age, I think it's really salty, but for them, they need to add something to it. And how many times, I don't like spicy hot food, but I like flavorful food, and there's a difference. So, so you need to, talking with people about how they're flavored. They're not getting the bland mashed potatoes. They're not having salt to it, but they may be adding other herbs and spices to it. And they do lose their sense of smell, which if you can't smell, food doesn't taste very good. I have a relative who's not been able to smell for many years due to a head injury, and she says, well, the worst thing is trying to find food in a refrigerator at appropriate times. So, but she always asks when I'm visiting her, does that smell done? Does that taste good? Because she can't tell. And then she's rather skinny. But so for her to enjoy food is not the same as for me. Her food tastes good, and I'm wolfing it down. She eats a couple of bites, but that's it. So when we get older, we have a very high risk for malnutrition. Why do we have that? One is because, again, we already mentioned, you're not eating as much, perhaps. But you also have some decreased absorption of some of the vitamins and things like this that we know when we're measuring them. We have malabsorption of your calcium, we already talked about. We have trouble with your bowel function, and that will add to some malabsorption, or malnutrition, and malabsorption. And people that get older have a lower intake for several reasons. One is the poverty they already alluded to with the socioeconomic things. The other one is isolation. They can't get to the store. And eating by yourself is really hard. If you have to eat a meal by yourself, what are you going to eat? You're going to grab something out of the refrigerator or out of a can, something, or else you're not going to eat. And that's what happens with the elderly when they're by themselves. It's stated that about a third of the people over age 65 eat alone, and about half of them over age 85 eat alone. And we see this when we have people come to the nursing home, which I think is the end result of this. They're severely malnourished, and it takes about 3 to 6 months to get their strength back, to get them doing normally. And by that time, they've lost their house, so they have to stay there, which is sad, but it's a social commentary. But they go to the dining room, they eat with other people, and this is why it's important for, to get them out, be able to have access to be able to eat. And again, have the support of family, of community. We have depression, we have dementia, adding to that. We have, and we'll go over some other things. Okay, we went over medical, psychiatric factors. Physical changes, we have anorexia, which can be related to the medication, can make people so they don't feel like eating. The stomach may not be emptying correctly. They may have constipation with bloating, and they just feel like they can't put anything more in there. And we know that the older people and some younger people are more perseverating on their bowels, and there probably is a reason for that, because they know that if their bowels aren't working, they do feel more uncomfortable, and they just can't eat, and it's part of the whole process. They may have more nausea and vomiting, especially with the change in the esophageal motility. Things just don't go down right. They have trouble swallowing. They have trouble getting the food through their mouth back to swallow it. And they may have trouble with that even without aspirating, even without coughing while they're eating. It'd be silent. And we all, the speech therapists and the video fluoroscopies always say they have silent aspiration. I'm just going, okay. But, the number of people that are coughing in the dining rooms in the nursing homes is much lower than the percentage of people who are actually getting actually aspirating. Many of the older people have dry mouths, and it's not because they're giving talks or anything like this, it's because they have less saliva. One of them is because they're taking medicines, which makes them very dry. If you've ever taken any medicine for a bladder spasm, you know you're dry. And how many of the older women are on that medicine for their bladder? Makes a dry mouth like you've been outside all day and not had any access to water. Antidepressants do that, some of the antihypertensive medicines. And we mentioned this morning about the teeth. You look in the mouth of those individuals, and their teeth are in poor repair. They may have one or two left, and they can't chew, they can't eat food, and so they eat mush at home, and they don't get adequate calories, they don't get adequate nutrition. That's part of it. So they're not able to chew correctly, they're not able to get the food down and swallow it correctly. So it starts, they don't have access to the food, they may not have access to get it through their mouth into the stomach. So it starts from the very beginning, works all the way through. Okay. So we're going to look at some of the diseases that make a high risk for malnutrition. And these are the very common things that you see in most of the individuals in the United States. It's very rarely that you see a person over the age of 50 to 60 who does not have one of these disease processes that we're going to go through. Their increased catabolism I put in there because that would be what we call cachexia. We see that you used to see it commonly in people with cancer, with bad cancer, with metastases, where they have the pro-inflammatory cytokines. We also have the same thing in people with heart failure, COPD, and it's also been described in end-stage dementia, where people are just losing weight. The end process where they're just becoming cachectic. You can feed them all the calories, we give them the supplements, do these things, and they're still losing weight. In spite of what Medicare says, they're losing weight. And so we have to write down that it's expected because end of life, and we just, it's called documentation. But these people is related to, their metabolism has changed to the point where they're not able to sustain themselves. And you can give these people all the calories you want, but you're not going to be able to reverse them. We've seen that with people with cancer. We've known that for years with people with cancer. But we also know the people with bad hearts that become the cardiac cachexia, people with end-stage lungs where they just are skin and bones. And again, you just try to fatten them up, but it doesn't work. It's an inflammatory process. It's a metabolic process. Okay, if we look at dementia, early on in dementia, there's all the stages of Alzheimer's dementia, and what we're going to be talking about is the people moderate to moderate severe dementia, not the early stages. But we have many of these individuals may be isolated. They may not be able to prepare their food if they're living alone. They may not be able to remember, or they've been told not to run the stove, or they don't remember how to run the stove or how to run the microwave if they don't have somebody with them. And so it's a mixed bag of how they can end up with a malnutrition, especially if they're living alone. Again, we're talking about individuals who are living alone, who have limited support. And we do have those out in the rural areas as well as in the cities. Heart failure. I mentioned there's severe end-stage heart failure, but even early on, and somebody who's bad heart failure who ends up going to the hospital, they have edema not just of their legs, but of their intestinal tract. They can't eat. They're nauseated. Nothing is working right. Nothing is absorbed. And so you try to get them to eat something, and it's just not going to happen. If they've been on digoxin, we know that digoxin makes a person nauseated, can alter the taste of food, their taste buds, and all sorts of problems. And also, if they're really dyspneic, you can't take a drink of water or eat. If you're fighting to breathe, how are you going to stop breathing to take a bite? You can't do that. And many times, these people are, they've been slowly getting worse, so they've been in and out, getting better, getting worse, and it's a slow process. It's like coming down off the mountains. Sometimes, like when you're coming off Beartooth Pass, you're dropping. But most times, you're coming down, and it's a slow process where they get worse, and then they get a little better. They get the heart failure under control, get a little bit better, then they get worse, with the heart failure gets worse, and then they get a little better, and it's a slow downhill slide. It's like when you're coming down through the mountains to the foothills, and then down to the river valleys. Chronic kidney disease is the same sort of thing. You have nausea with kidney failure. You have edema. Same story as with the heart failure. And then you also have the acidosis with the renal failure, which if you look at the serum electrolytes, the serum bicarb is low. And that makes a person short of breath. It makes a person nauseated. And it's one of those things that the docs, nurse practitioners need to be looking at and giving medication to help combat that metabolic acidosis. And also when you have renal disease, you're on a lot of medications, usually for your blood pressure, for edema, and those are going to really affect your oral intake. COPD, by the time a person with lung disease is on oxygen, they're pretty dyspneic. You know, they may not even, they're on oxygen tubing throughout their house, and you can find them by following the tubing. You know, the woman told me that she takes it to the door, and then she takes it off there, and she goes outside to feed the cats. Then she comes back in, put her oxygen on, and goes about her day. I'm just waiting for the time when she's going to go out there, feed the cats, trip and fall, and then she'll be in the hospital. And we'll just see how, you know, what kind of shape she will be in when she comes in. But her cats are the love of her life, and they keep her going. But again, COPD, all of these people will have some severe fatigue. I'm not talking about the fatigue when you're done with a shift and you're ready to go home, you've been working hard all day, you're ready to go home. I'm talking about the fatigue where you feel like you're walking through water, that taking a step is feel like you have water up through your thighs and you're walking through that, or walking through snow. That's the fatigue when it is hard to even maneuver, when you feel like you cannot get out of low gear or first gear. That's the fatigue that you're talking about with these illnesses, with the heart failure, the COPD, the kidney disease. And you can tell how well their disease is going by how fast they're moving. If they're barely moving, you know that they're not in very good shape, and they're not going to be able to eat, they're not going to be able to take care of themselves. But if they're moving along, then you can say, well, yeah, they're going to be able to do that. So again, just as an eyeball test, there's nothing, no major support for that, but just as an eyeball test of how they're working. Cancer, we have a long history, a lot of information about people with cancer. Some cancers make a person nauseated early on. The chemotherapy is, you know, historically known for that, and now we have some wonderful medications now to help suppress that, and they're working much better for that. But again, when people reach towards the end of their cancer, they have a lot more problems with that. And again, trying to support these individuals through their disease process is difficult. Cancer is the second cause for weight loss in the elderly. The first cause is depression. And so you think, oh, you know, I was just at a conference and they say, mild to moderate depression in the elderly should not be treated with medication. Right, okay. But then you need to look at what is going on with them. If they're not eating, they're losing weight, they're not functioning, that's probably more than mild to moderate depression then, isn't it? So it's a severe depression. But it's, and so again, looking at all these things, you have to put the picture together. People who have chronic illness are depressed. There's information out there about people who've just had a stroke do better if they're put on an antidepressant right after they have the stroke. And recover better. One disease I did not put on here is diabetes. Diabetes usually ends up with people with vascular disease, heart failure, kidney disease, etc. But diabetes by itself, without causing the microvascular disease with the renal disease, can end up causing with the neuropathy where they're not able to function. They have the gastroparesis. It has its own milieu of things that can cause a person to not do very well and have malnutrition. Specifically the gastroparesis, where they vomit, and the colon's not working very well. They have diarrhea, constipation, and it's a heart disease. And many of them are put on this strict diet when they're 50 years old for a type 2 diabetes, and they reach 80, and they don't want to have chocolate cake. I'm going, let's have chocolate cake. You know, let's enjoy things. Let's put some ice cream on it too. You may not need to have the whole piece, the whole cake, but let's have some cake. You know, my grandmother always made a cake in a 9x12 pan, and she cut it in 6 pieces. Yes. So, okay. Strokes can cause malnutrition, and you can see, you know, you can understand that. Somebody who has trouble swallowing, somebody who can't feed themselves, they have a tremor, they have a paresis, they can't get to the store, they can't get to the refrigerator, they can't get to the stove. All of those things make a big difference. The other part of this is, I didn't put on here bladder problems, but I should, because many women who have bladder problems, spastic bladder, can't make it to the bathroom, they stop drinking, they stop eating. And you see that many times in individuals because, and they come in dehydrated, and you can't, you have to talk with them about drinking, and especially if they have trouble with their bowels after a stroke, they're not going to eat very much because, as we know, you eat, you have a bowel movement. It's hard to educate people that most of the stool is not from the food that you eat. And so, that's a hard one to do. Chronic pain is something that the elderly have. They have arthritis, they have prior injuries, they have had surgeries, they have all sorts of things that can cause chronic pain. The medications can make it so the person is not able to eat very well. We know the narcotics decrease a person's appetite, causes anorexia. But also, when you're in severe pain, you don't want to eat. You just want to sit there and help control the pain. You may not want to, do much of anything. And so, again, it can help affect your mobility. We talked about isolation, and part of the isolation is also neglect, abuse, and those situations which are not a pretty picture. And part of that is part of the support system of what is the support system for this individual, for that family. Sometimes you're going to be dealing with both husband and wife. You may be dealing with siblings, two sisters who are living together, a sister and brother. So it's a support system of who they are. Here, we know that the children grow up, they move out, and they may come back only once a year to see their parents. And their grandchildren then are living elsewhere. So they have to continue to stay in Montana, so they may not have much of a support system. Drugs, I already mentioned digoxin for one of the drugs, which causes a lot of problems. I'm going to go through those a little bit more in a little bit more detail. Mobility is one of the things, again, related to people with strokes, people with pain, people with heart failure, COPD. All of those people have mobility problems. Whether it's getting out of the house into the car, getting out of the house into a van, getting out of the house, getting off the chair to get out of the house. So getting out of bed to the chair. All these things are mobility issues, and just evaluating them. When you see them, we'll go over some of the things of how to evaluate those. But again, just to eyeball them and see how they're able to function. And you can predict if they're going to be able to live independently or whether they're going to have to go into an institution of some kind. There's a study in 1996 which showed that 20 to 30% of elders who are living in a community had a disability of mobility, and also had one ADL function that was missing. So that's pretty significant. I think that's a large amount, and I really don't think we have the support system for them. Infections. We know that when somebody has, if you've ever had a pneumonia, ever had a major flu, major infection, it takes you about 3 months to recover. Elderly don't have that long to recover. As we heard, they spend 1 day in bed. It takes 4 days for them to get back up on their feet. So they go in the hospital with a simple pneumonia. It takes them a long time to get that appetite back, get that nutrition back, get rid of the antibiotics, so maybe they end up with C. diff, and then we're in a whole nother ball of wax. The other one is TB that we don't see very much anymore, thank goodness. And we don't have very much AIDS around here, so we're lucky with that. The other problem is financial, which is again part of the psychosocial. If people don't have money to buy food, they don't have money to pay for a cab, to pay for special transportation, pay for a bus, they're not going to be able to get it. If they have Meals on Wheels, there is a waiting list for Meals on Wheels in Billings because they don't have enough drivers to take them out. And so some people, and many of these people, over 80, lived through the Depression. They get food, they're only going to eat half. And so they'll save it. so they're not getting adequate calories in either. Okay. So when we see these individuals, we want to look at what their goals are. Again, that goes back to the capacity side of what is their values. What is their goal of therapy? What would they want to have done? This is part of the conversation when you're talking with these individuals. You can look at the disease process. Taking care of the diseases is fine. Treating blood pressure is easy. You take a reading, you adjust the medicine, and there you go. Taking care of the diabetes, you get the sugars, you look at the diet, you look at the insulin, the medicines, and there you go. It's the life that makes the difference, and that's the quality of life. What is important for the individual? What keeps them going? What allows them to get out of bed in the morning? Maybe they don't have anything to reason to get out of bed, but it's not work. You don't get out of bed for work. Sometimes you have to, but that's not the real reason for getting out of bed. The real reason to get out of bed is something that is important for you, something that drives you internally, and that's what makes you get out of bed. So, and that's part, again, the quality of life. You want to know what advanced directives, how the family is involved with that, and again, what the POLST is. And everybody in the nursing home knows what a POLST is. That's the provider order for life-sustaining treatment. And it's very nice to know because it's a nice little summary sheet of what we assume that person would want. But again, this is part of the discussion when you're talking with people. And anymore, I try to make that even almost the beginning of my discussion before you go through all of the other stuff. Because if you have that at the beginning with the individual and their family, then you know how they've been handling it. The medical history is usually written down somewhere, so you don't even have to do very much interrogation about that. But very few people have evaluated people about some of these other issues. We want to look at what their BMI is. I don't like looking at that. But in the elderly, their optimum BMI for the elderly is about 22 to 29. Much bigger, because we have reserve and we can handle a crisis. When 2000 came around, I thought I'm in shape. I don't have to worry about, running out of electricity. I have reserve. So, but if we have, and it's been shown that people, elderly with a BMI less than 22 have a higher one-year mortality. And if women over age of 75 have a BMI less than 22, have about a 40% higher mortality than those who are a little bit larger. And for men, it's about a 20% higher mortality rate. So it is good, in spite of losing the muscle, in spite, maintaining the fat. But this again indicates how healthy that person is, how active they are. If somebody who has a chronic disease has not been able to do very much, and their skin and bones, we know how badly they're going to be doing. There's much information in the palliative literature about predictability of how people are doing based on weight, function, and things like that. I didn't put that in these slides. The mini nutritional assessment is a quick questionnaire that the dietitians go through, and it basically does some body measurements. In the general assessment of whether they're living independently, how much they're eating, how much stress they're under. A dietary assessment of how much they're eating. Do they eat full meals? Do they eat partial meals? Do they eat any protein? Do they eat? My older sister lived for quite some time on popcorn and Diet Coke. And she doesn't now, but it took her a long time to get her out of that habit. And then a self-assessment, asking the individual, how are you doing? These people have lived a long time. They usually know how they're doing and what's going on with them. Okay. And the simplified nutritional appetite questionnaire is, again, another quick thing of how is your appetite? Is it good, poor, very poor? How is your appetite? When I eat a lot. I fill up easily. I can eat a whole meal. I can eat only half a meal. And part of that question is eating a whole meal is you have to see what size serving they have. I've been in a hospital where people ate 100% of their food was one piece of toast. And they ate 100%. So you need to know what is going on the plate before you can say how much they ate. And so people say they eat everything they had on their plate. You need to answer that question. It's like somebody who says, I only have one bowl of ice cream. How big is the bowl? So, and then ask the question of how does the food taste? Does it taste good? Does it taste bad? Does it have any flavor? Do you have to add salt to it all the time? So, and how many meals do you eat? Do you eat 1 meal a day, 2, 3, all day long, 4 meals a day, those type of things. So again, that's just a quick little a simplified assessment, but you can do that just asking people again what they're eating as part of the assessment. And that is part of seeing what they like. When the family comes over, do they bring them over ham, bacon, chicken noodle soup, those type of things? Or do they bring them over vegetables, cottage cheese? You know, thinking of the salt load, the protein load, what are people bringing them when they're bringing food over? Okay. And when we're looking at somebody, we want to look at, again, related to their disease process. We're doing a general exam, but if somebody has heart failure, we want to be looking at things related to heart failure. How much are they able to do? How much are they able to breathe? Somebody with lung disease, how far can they walk before they get really dyspneic? How much can they talk? Are they talking like this and they can't get any words out? Either they're really weak, they can't get any air in, or they have no energy to, they have so much fluid overload or bad lungs that they can't talk. It could be perhaps that they're nervous, but, I don't usually look at that. I usually look at the other things. So you can tell what their speech is, how their movements are, and that's part of your assessment. The other thing is part of the history that you'll get from the papers is where they are in the disease process. If they've been in the hospital several times, or they're in the hospital for the 3rd time this year, or the 3rd time in 3 months for heart failure, you know where they are in that disease process. Either they're eating too much salt, they're not getting their medication, they don't have anybody helping them, and so you know that they're going to be at much higher risk for malnutrition in those individuals because they're just not. Every time they're in the hospital food is better now, but still you have to feel good to be able to eat it. And if you have edema of the gut, you're not going to be absorbing it. And so looking at those things. Okay. We want to look at the medications. The sheer number of pills. Are they taking all their pills in the morning and that's their breakfast? You know, they tell me that if you take your medicines in the morning, it's still fasting. So therefore, there's no calories, there's no nutrition in it. So again, looking at the number of pills, when they're taking them, whether they can be spread out during the day, and the type of medicines. There's some of the medicines cause anorexia, severe anorexia. Again, digoxin is one of them. The protein pump inhibitors, the omeprazole, those things can cause them. SSRI for depression can cause nausea. And some of them, if an empty stomach is worse than a full stomach, those things. Your pain medicines will cause that. I'm just listing some from the list. Behavior problems, behavior reactions. Again, your anticholinergics. If somebody has a little dementia, you give them something for their bladder. They may not be acting quite right. Drugs that alter taste, so that they're able to eat well, but all of a sudden things taste metallic. The metronidazole that you give for C. difficile is classic for that. Your ACE inhibitors are classic for that. Things taste metallic. And if they're taking iron, things don't taste right. Digoxin will do that. Antihistamines will do that. And things that can cause some dysphagia. Again, these are common medicines that people are on. Antibiotics can cause people where they're upset, they're not able to swallow right. The bisphosphonates cause heartburn. And how many of the elderly are on bisphosphonates for their osteoporosis? So, okay. So, and these are common medicines. So, and many of them can cause constipation or diarrhea, or both. And so that affects how much people are going to be eating. We all know, in looking at these individuals with chronic pain, chronic illnesses, they may have depression secondary to that. They may have had depression all their life, often untreated, not treated, up and down. So just doing the geriatric depression scale that social services do, but you can do a quick one of just asking people, what gets you out, again, what gets you out of bed in the morning? What makes you happy? Are there other people that you're involved with? So do you have a connection? Maybe somebody that you're calling on the phone once a week, a relative, a child, a friend. And what are your goals? Do you have goals over the next year or two? Are you going to finish that quilt? You have to take care of your cat. You have to do these things. What are your goals? You're going to go on a cruise with your great-grandchildren. You might be surprised what the goals are. But that gives you sort of an idea of how isolated, how depressed they are, of whether they're reaching out or just have pulled in. The Get Up and Go test is really a lot of fun. It is, you have a person sitting in a chair. Do you want to show them? Oh, no, she doesn't want to model it. This is a test that allows you to figure out where the person, basically it's a good test for showing people where they're going to be able to live at home, because it says where they can get up out of a chair, get off the toilet, is the main thing. So you have a person sitting in the chair, you have them get up and walk. This is on the slide of how to do it. You have them get back. You time how long it takes. When I saw a person in the office, they're always in a gown on the exam table. So you don't really want somebody getting around walking in an exam gown. But you can do that when you're looking at somebody. When you're visiting your grandparents, your parents, other people, you can see how well they're able to get up and do it. When you're doing that, you can see their balance when they're sitting. If they're sort of weaving a little bit. How easy it is for them to transfer, how easy it is for them to turn, and what their pace is when they're walking. If they are walking through water and they're barely walking, or whether they can just stride right out. So, and this is it's an easy test to do, and again, something that any of you can do. Just sort of check it yourself and see how well you do. You can't use the arms of the chair to get up. If you're skiing, you can do it. If you've been skiing, because you have those muscles in shape, okay? I don't know if you've ever noticed, at the beginning of the ski season to the end of the ski season, you can get out of a chair much easier at the end of the ski season. Okay. So you're supposed to walk for 10 feet, turn around, walk back to the chair. If they can do it in 7 to 10 seconds, they're fine. If they do it in over 10 seconds, they have a higher risk for falls. And so if it takes a little bit longer, they can usually be independent, but you need to be aware of that, and they may need more help. Just be aware of that and sort of, okay, watch this, more therapy, lifeline, all sorts of other things to get them going better. Okay. Evaluating for the ADLs. Now, you all know, as nurses, you know what the ADLs are, right? I didn't for years. There's many things you don't learn. But again, knowing what people can do, what they can't do. If they can bathe themselves, if they can feed themselves, dress themselves, toilet, on and off the toilet, cleanse themselves, those type of things. And it's important to evaluate those. I've had women with long fingernails, and I've often wondered, how do they function, do all their ADLs? And they refuse to have them cut or trimmed or removed. And so I think that's a limiting factor. I don't know where that goes in this whole process, but I think that's a high-risk item. Instrumental ADLs are ones that take a little bit more thought process. Again, you're driving, you're cooking, you're cleaning. Again, if a person can't drive or clean or cook, they're living by themselves, they're at much higher risk for malnutrition, much higher risk for not being able to stay by themselves for long unless they have a really good support system. So, okay. Now, assessment of this, we're going to be looking at your x-rays, the usual thing. Speech therapy is not something you usually see when you have somebody in the office or in the hospital. But if you're seeing somebody who's having difficulties, you may want to recommend or get a speech therapist in there because they can evaluate, number one, what their swallowing is and their cognition. So they can tell you how they're going to be able to handle some of this stuff. And they're a very key portion of the therapy as well as the physical therapy and occupational therapy. In the laboratory data, you're going to do your basic chemistry. You're also going to be looking at your vitamin D because we know that when you have vitamin D deficiency, you are weaker, you have less strength, you can't walk as well, you have a higher risk for falls, your heart function is not as good. So there is a reason for giving people vitamin D. You want to check your thyroid and your parathyroid hormone, which actually also adds to your bone disease and your overall metabolism. Okay, so what we want to do, you get all this information, you have all this history, you see how the person is doing, but then you want to look, you pull back and you say, okay, what are we going to do with this? Okay, check my time. I hate it when speakers go over time. I do not do that. Period. So, again, we want to look at, are we doing harm, the benefit and the burden, and the autonomy, the self-determination. So you want to look at, to have an open discussion with the family, with the caregivers. You want to have the whole multidisciplinary team meeting, which includes your pharmacy, your dietary, your nurses, your physicians, your mid-levels. If they're in a hospital, in a nursing home, or an assisted living, all the people that are, again, connected with these individuals. And you have to be honest. How many times have you had somebody comes to you and they say, well, they have no history about how bad cancer is. I mean, that's the classic one. Or their heart, or their lungs. You may not want to be brutal, but you want to be honest. And so people understand where they are in the process. And I think that's, the longer I do this, that's more important. I've always been honest with individuals. But because the families need to know where they are. Family and the patient needs to know where they are in the whole process. As the question was this morning, if somebody's sitting in ICU, I've been there. You have somebody in ICU for a couple of months. The physicians know they're never going to get off the ventilator, and they're maintained there. And the family and the neurologists come and say, oh, the brain is doing fine. Pulmonary docs, oh, the lungs are doing fine. Hearts are doing fine. Kidneys are on dialysis. They're doing fine. The person is not leaving the ICU bed. So you need to have somebody who's the holistic approach. And that's what, again, I love about nurses, is that nurses are holistic, and you're just that way. And that's why I love working with nurses, because it balances. I was not taught that way. As physicians, we're not taught that way at all. So I've learned a lot from my nurse practitioners. Thank you. So you need to, again, reviewing with the patient, with the family, try to get a plan of care. Now I have a case that I created, and I'm just going to read it out. Oh, I have it on the slides here. It's an individual I just created out of my brain. An elderly woman living independently. She did get a lifeline, and I didn't make up how she got one. She probably was in the hospital previously. Similar event, and somebody said, you need one of these. Daughter said, oh, he'll sign you up. So she has a lifeline. She fell at home. And by the way, her house was a little bit filthy, the ambulance crew said when they brought her out. And after talking with her and reading some of the older records, we know she has high blood pressure, diabetes, osteoarthritis, but she doesn't know what medicines she's taking. And how does that happen? I've had individuals in the past that have a bowl of their medicines. This is back before we had generics, so they had all sorts of nice colors. And one day they would take a red one, the next day, oh, it's green day, pink day, multicolored day. So every day was a different pill, and you never, who knows what, you could get a pill, look in the PDR, and find out what it was. But it was just how she was feeling that day of what she would take. That happens more than you would like to know. So, and she hasn't seen her doctor for a year because she can't get out. She can't walk very well. She has nobody to drive her. She doesn't really want to bother anybody. And so she got a front-wheeled walker from somebody, and so she uses that when she has trouble. And she takes some ibuprofen for her arthritis. I had a gentleman the other day who takes a concoction. He takes a little ibuprofen, a little naproxen, a little acetaminophen for his arthritis, about twice a day. I'm going, ooh, as a nephrologist, I can see his kidneys going. So, and she takes their vitamins for her eyes, though, every day. She was told to do that by her eye doctor, and she gets those. You know, many places you can get your medicines delivered to you from, for the pharmacy. There's also other things you can get delivered to your house, groceries, your alcohol, things like this. So that's one thing to ask about. I found that the hard way one day, that I'm going, they don't drive, how do they get their alcohol? Well, they had a neighbor come get it, or they called them and they had it delivered. So she has macular degeneration, as we figured from her vitamins for her eyes. She gets Meals on Wheels. She gets signed up for that, but she makes them last for several days. Children are out of town, or out of state, but they do to come in. When we saw her, she was very thin. She could talk clearly. She could tell us what was going on, but on an exam, you can see her. She was quite hypertensive. She had a little aortic murmur, or heart murmur, and she had a lot of arthritis in her hands and her feet. She had some edema. Her potassium was up, her sugar was up, creatinine was up. So she has some her sugars are not controlled, kidneys are not working, probably related to the diabetes, hypertension, and her ibuprofen. And she has an enlarged heart, she has a little heart failure. She had the hip surgery. That went beautifully, no problem at all there. Good surgeon, good anesthesiologist. And so now we need to start thinking, okay, let's sit down and see what's going on with this lady. What's the risk for her? We went back, let me see. I do have her, where did I put her BMI? She's very thin. So we're going to try to figure out what's going on. And what should be done when we're talking with her? What would be the next step? What would be, as a discussion with her, how do we want to present it? How would we see these individuals every day, don't we? Maybe not all this one, but we see a variation on the theme. How would we want to present it? How would we want to talk with her about this? Because we can see that her, that she is, that MNA score should be a BMI. I don't know what I was writing. She's very malnourished. So we see that she lives alone. The ambulance said their house was not clean. Macular degeneration, she has some vision difficulties. She has some ambulation difficulties, mobility. Her health problems are not controlled. So how would we want to review this? Okay, let's look at our ethical principles of beneficence, do no harm. If we were going to put her on medicines for her heart failure, her diabetes, her renal disease, all these things, she'd be on a huge list. Right now, she came in, she's taking 1 pill a day, 1 vitamin, and an ibuprofen, 2 pills a day. So we give her a long list of medicines. Would she take them? How would she take them? Would she she take them when she felt like it at all? She'd probably get it filled and put it in her cupboard, as many individuals do. Would it make a difference in her life expectancy if we treated her for her high blood pressure, diabetes, kidney disease? She's 85. We don't know what her life expectancy is. If we got her heart function doing okay, you probably got her kidney function doing a little better, get off the ibuprofen, getting her arthritis treated, we could probably make a difference in the quality of her life. So she'd have less pain, perhaps more mobility, better nutrition, some support somewhere, somehow getting her support. So we don't know what her life expectancy is. I would say she probably, best guess, we probably about 3-5 years, if controlling everything. So is her home situation safe? So we need to talk that over with her, because she has capacity. She can go back home. We can't stop her. We may not like it. It's like watching teenagers, Yeah, okay. So, but we have to say yes. And and again, part of that would be trying to figure out what would be, working with her and her family. What would be the support that she would agree to? What would be the support that would be appropriate for her? She's getting food. She's not eating it very well. I mean, she's making it last several days because she doesn't want to run out. She wants to have something there. Does she need family closer? Does she need to move closer to her family? I doubt it. Does she need maybe some arrangements for help to come in? What would be, we have to use our imagination of trying to figure out how to handle this. This woman who is severely malnourished has all these health problems, which is adding to all of that. And some of it's probably some stubbornness on her part, As we get older, I think we become more stubborn. That's what my husband says. Benefit and burden. Again, looking at what is the benefit, what is the burden of all the medications, support at home. Some of these people don't want anybody in their home. They want to be by themselves. No, thank you. And so, again, looking at that, how would we help her with any of these things, or does she want help? Again, that's part of the conversation. These things are never easy, and that's where ethics. With ethics, first thing you have to understand with ethics is there's no right or wrong, and there is no answer. It's a discussion. So, but would she want to move to an assisted living? Would she want to move closer to her children? Again, you have to think about all the options. Does she want to maybe move into, she has her own house, a big house. Maybe she'd like to move into a smaller place so she could bring her stuff with her. I don't know. We have to talk with her and show her the different things. In today's day and age, she's in the hospital. She's out of the hospital in 3 days after a hip, 2 to 3 days after a hip. Is that long enough time to have this discussion with her? No. She goes to recovery, rehab. She hears the word nursing home. She's out of there. And so, looking at what would be the conversation with her, because as nurses, I see somebody as a physician, I'm in there, I'm out of there. You know this. So nurses, working with her, working with the family, trying to help figure out, we have all these checklists, we have all this list of processes. Can we alter any of them? Can we make a difference? Can we help her? Look at her quality of life. So again, we've looked at the aging process. We've looked at the autonomy, her self-determination. We've looked at the benefits and burdens. Again, giving her the medicines, will it help? Will it make it worse? And we wanted to make sure we do not do harm as much as we can. Okay, open for questions. Any questions? I don't think we have a roaming mic, so you have to shout. Just pretend I'm a teenager. Uh-huh.
You said that, you figure this person that you were talking about, life expectancy would probably be 3 to 5 years if you were asked. But how many physicians will tell you even if you ask?
Very few.
You can't get an answer.
That's one of
Nobody knows.
Right. In many disease processes, it's hard to know the life expectancy of them. I think that Alzheimer's is one of the easiest ones to predict a life expectancy because you have the stages of where they are, how demented they are. And especially if they're not able to eat, they're aspirating, they're not able to swallow anymore, you know that they have probably 6 months. When we have to refer somebody to hospice and we have to say they have only 6 months or less to live, we know that if we refer somebody to hospice early, they live longer and they get re-upped. But so heart failure has a 50% 5-year mortality. Most people don't like to look at that. It's like as a nephrologist, nobody died from the renal disease. They all died from their infections. So, it's very hard to predict how a person is doing, but there are charts out there, you can look at it. You can look at how her kidneys are doing, how her heart's doing, all of her hospitalizations. You can give a good guess. Time? Oh, time. We're out of time.